This presentation considers the various instruments that will be used for soft tissue manipulation and closure during the workshop and the identification of these instruments. So the key point that we're looking at here is soft tissue is the issue, but bone sets the tone. Now obviously we want to close our soft tissues effectively. We want to use techniques that preserve our soft tissue and don't lead to flap breakdown or make it difficult for us to close the flap because we've ripped or traumatized the tissue in some manner, or even worse still, lost the tissue altogether, leaving a defect over our implant site. Now the instrumentation that you'll be using during the workshop will be the locus bone curettes, of which we use 3 sizes. Lucas actually has 4 sizes in their standard range. We only use the first 3. Periosteal flap elevators, of which we use 2 types, angled scalpel handle, Castroviejo needle holder, and Adison's forceps. These are the instruments you will be using on the clinics, and we need you to be able to identify these instruments and become comfortable with their use. Now let's start with the Lucas bone curettes. We are using 3 sizes. These are the 2.4, 2.7 and 3 mm diameter ends. If we look a little bit more closely at these instruments, you will see that they have quite a long reach on the working end. Now this permits us to reach the bottom of our sockets when we're doing debridement of extraction sockets. So for example, this is the length of the arm we need. We have the spoon end with the sharp cutting area for removing granulation and fibrous tissue, but obviously some sockets can be in excess of 12 mm long, and we need this long reach. If we were to use normal curettes, they wouldn't have the length to be able to reach the base of the extraction socket. Now, as you appreciate, the extraction socket is tapered, and towards its apex it becomes very narrow, and this is why we need the different diameters of spoon end starting at 2.4 mm, because this will reach the very apex of most extraction sockets. The next diameter is this one at 2.7, and again it may reach the base of some extraction sockets, but others like incisors or small lateral incisors or lower incisors, this may not reach the full length of the socket, and so you'd want to use this one. And finally, for bigger areas, you would use this wider spoon at 3 mm. Now, what are their uses? Well, we use them to remove fibrous tissue and bone. This is very important when perhaps we're uncovering an implant, maybe bone has grown over the cover screw, and we need to be able to access the platform of our implant in order to attach our healing abutment. But at the same time, we don't want to over remove bone, which might occur if we were to use a powered instrument with a burr. Occasionally there's quite a lot of fibrous tissue in the area, and again this needs to be removed. We've already discussed the use of these instruments in extraction sockets for debridement and removal of granulation tissue, and again the exposure of implants is a very useful instrument to have on board. Now, when we're looking at periosteal flap elevators, we use 2 types on the program. We use a palatal flap elevator called the Harding pattern, and we use the mini periosteal elevator, the Boozer pattern. And they're used for reflecting and retracting mucoperiosteum. They have sharp edges that cut through the periosteum to avoid tearing of the soft tissue or tissue trauma. So these instruments have cutting edges, and this is most important when it comes to dissecting the periosteum away from the bone and causing minimal trauma to both the bone and the soft tissue alike. So we'll start with the palatal flap elevator, and you'll see there's two ends to this instrument. The first is the curved end, and it is used to raise palatal flaps, and it's used in a pulling action. You pull it towards yourself, and this is where you've made an incision in the palate, and this curve, if you like, engages under the palatal incision to help you raise the flap. And this elevator has been specifically designed for this purpose. If you try using conventional straight elevators, it's very difficult to actually access the palatal flap to raise it. So this is an important part of your kit, and when you're on the surgery sessions, make sure always that this instrument is available, especially when placing implants in the upper jaw. The other side of the instrument has this less curved spoon end, and again this is used in a pulling action, and it's mainly used to raise buccal flaps in the posterior mandible. And as I say, its application is to raise mucoperiosteal flaps in the upper jaw and from the palatal side, and to raise buccal flaps in the lower jaw. The next instrument we're looking at, which is very, very useful, is the mini periosteal elevator, the Boozer pattern, and this instrument is very useful as often we're raising only small flaps, maybe single teeth flaps or multiple teeth. We're talking partially edentulous patients, and this instrument is very easy to use. And again, we have two parts of the instrument. We have the narrow pointed end, and this is for use interproximally, and it's used around the papilla. You've raised the flap and you've made an incision, you've done a cervical incision around the tooth, and now you have to start in the papillary area to raise the flap, and this will just get under those papilla and help raise the flap in these areas. It's used in a pushing action. The instrument is also very useful for stabilizing membranes when you're doing grafting techniques, in that you can use it to help hold the membrane in position against the bone, or to push it under the flap if required. And I also use it as a directional indicator by pushing it palatally along the palatal shelf under the gingiva in the palate to help get an idea of the angle of the palatal bone. So a very useful instrument indeed. Then we have the other end of the instrument, which is this sort of spoon-ended area. Again, the top area of the instrument has a cutting edge to it, so this area along here is very sharp, and I find this particularly useful for elevating small flaps and also for elevating flaps in the posterior mandible. It's used in a pushing motion and a sliding motion as well, and this will be demonstrated in video tutorials later in this presentation. Features: it's used to raise small periosteal flaps, and it helps to preserve or limit the damage to the papilla, and it can be used to support membranes, as I say, during grafting and tissue augmentation procedures. Now we have the flap retractors. Oftentimes I see these being inappropriate appropriately used, especially the curved end, and often surgeons may try to use these to raise mucoperiosteal flaps. These are flaps raised which have periosteum. They can be used occasionally to raise mucosal flaps which have no periosteum. That's a different matter, but if you have periosteum attaching the soft tissue to the bone, then you need a retractor which has a sharp edge, or an elevator, that has a sharp edge. These are retractors and they're used to hold back the tissue. So the application is to retract and support soft tissue flaps to improve visibility. They're not used to raise or as tissue elevators to raise flaps. They're used to protect the soft tissues and the vital structures such as nerves and blood vessels, and to protect the tissue maybe when you're using rotary instruments. The last thing you want to do is lacerate or cut up the soft tissue forming the flap. And they should not be used for keratinized tissue elevation. The smooth edges do not cut through the periosteum, and if you try to use them for this purpose, you often end up damaging the flap or not lifting the periosteum cleanly, leaving areas of attached periosteum to the bone, which can affect healing later on. So the one end has this curved end which fits nicely into concavities in the buccal plate produced as a result of bone resorption or defects in the labial plate caused during tooth extraction. It's not uncommon that when you raise a flap in the maxilla, in the traumatic zone, that you might find dips in the bone, and this curve just nicely fits into the dip, maximizing the bone contact that you need to be able to support and stabilize the instrument during reflection of the soft tissue. And as I say, it may be used to help elevate mucosal flaps, but not mucoperiosteal flaps. As it does not have a cutting edge, it will not cut through the periosteum. The other end of the instrument has this flattened surface with a slight curving, and this rests on flat bone surfaces that may be found on the buccal plates, buccally or lingually, in the posterior mandible and also in the anterior mandible as well, but to a less extent. You may find the curved end serves better in the anterior mandible, especially lingually, where the bone tends to be curved in a sort of arc on the lingual surface. So this instrument, the curve, can help fit under the flap, again to provide extra retraction and improve visibility during your surgical procedure. So do not get confused between the two types of instruments. One is a periosteal elevator, which has sharp edges and used to cut through the periosteum so that you relieve the flap from the bone, and then these are retractors which are used to support the flap once it's been raised. Next we have the angled scalpel blade. Now many of you will not be used to using this. A number of you will be using the straight blade holder. During the course of your training you'll be introduced into this using this scalpel holder, and you'll find it far easier to use than the straight, especially as you get used to it, and eventually you'll wonder why you ever use the straight handle. This course is not just about getting you perhaps licensed or competencies to pass any implant examinations, but also about improving your skills as a surgeon. Application. It's used to access difficult areas to reach in the palatal and lingual areas, and this blade is very useful when it comes to raising a flap in the posterior mandible, in the 6th area, between the 7 and the 5. It's very easy to get the handle in, it's far more difficult to use a straight handled instrument. Now the blade we use on the program is the 12D blade. This picture shows the important point about the 12D in that it cuts both on both sides, both the distal and anterior side of the blade has a cutting edge to it. This is very unusual as most blades only cut in one direction. Its application is that because it cuts on both sides, it's very useful for outlining flaps on the palatal surfaces that you need to be able to close over extraction sockets. So you might want to raise a pellicle sort of flap, and these scalpel blades, because they cut in both directions, make this a lot easier. And again, you'll be seeing examples of this on the clinic as you proceed through the program. The Castroviejo needle holders again are very useful. They take a little bit of getting used to, but at the end of the day are very useful. They're used in microsurgery. You'll find that traditional types of suture forceps are really not that useful and easy to use at the back of the mouth. It's used for delicate suturing in difficult to access areas of the oral cavity. It's used in a pen grip, and the springs at the back of the handles help to open the forceps and the jaws, rather like a pair of tweezers are spring loaded. This feature is shown at the back of the handles, where you have this spring that helps to open and close the jaws of the forceps and securely hold the needle during suturing. The next instrument we use is our Adison's forceps, and these forceps are very useful for holding the flaps during suturing. They have very fine tips which give good visibility, and also when you've got a small area of soft tissue to suture and very little choice for entering the soft tissue with a needle because there's so little soft tissue for the needle to go into, the last thing you want is forceps that cover large areas of the soft tissue and prevent you from inserting the needle. So this is why we like the Adisons. There are two patterns of Adisons you'll commonly. One I prefer using is the rat-toothed end of the Adisons, and these teeth engage and hold the flap securely so that when you insert the needle, you've got hold of the tissue, it's not going to push away from you. The one disadvantage of this design is that if you try to use it to pull the flaps together under tension, you will end up ripping the tissue, which is the very last thing you want to do to the tissue. So they have to be used carefully. So if you think you're going to have problems using them in the correct manner, then it's probably best to use the ones that don't have the rat tooth feature. Application, well, they're used to reposition and hold the soft tissue securely during suturing. The rat tooth grabs the soft tissue, as I said, to resist the displacement force generated as you try to push the needle through the soft tissue. And later on in other presentations, you'll be looking at needle design and how the needle design can help reduce the amount of force you have to use to actually push the needle through the soft tissue. Safety precautions are very important because we want to limit the occurrence of percutaneous injuries during the use of surgical instrumentation, which aren't uncommon, and so care needs to be influenced or exerted when using all sharp instruments. Now, in this interesting article looking at percutaneous injuries in dental professionals in the Washington state, the aim of this study was to identify the circumstances and the equipment related to percutaneous injuries among dental professionals. The importance of this study is that percutaneous injuries or incidents expose the operator to blood-borne transmission of pathogens such as HIV, HCV and hepatitis. Now, this survey looked at 4,500 percutaneous injuries of healthcare workers in general, and found that 20%, almost 1,000 people, were due to dental professions. So out of all the injuries that occurred, dentists were responsible for 20% of percutaneous injuries that were reported by healthcare workers. Out of these 924 percutaneous injuries reported, 79% were amongst dental care professionals in non-hospital settings. In other words, the greatest chance of stabbing yourself with an instrument is going to occur not in a hospital setting, but in a general clinic, as many of you operate in. Interestingly, when we look at the figures related to the individuals that managed to stab themselves with instruments, these were dentists at 7%, dental hygienists at 18%, and our dental surgery assistants were the most likely of all dental care professionals to impale themselves with a sharp needle or instrument. The majority of those reporting the accidents were females, and when one considers that the majority of accidents occurred to surgery assistants and the majority of these would be females, then we can see why this figure of 71% is prevalent to females. I don't think it is an indication that females are in any way more clumsy or prone to the accident. It's just that there's more female dental surgery assistants in the Washington area, most likely, than there are male assistants. Most of the injuries involved syringes, which were needle stick injuries. Dental instruments were 9% and suture needles were 23%. Now, obviously, we're going to be prone to all of those doing our implant surgery, and perhaps the suture needles are ones that we need to be aware of, in that many dentists who do a lot of suturing, it's not uncommon occasionally for them to cut themselves with their suture needles, or for our surgery assistants when they're tidying up to accidentally prick themselves with the suture needle. So the suture needle is something we need to be very aware of, and of course during implant placement we're going to have this chance. Also, as we've mentioned, the periosteal elevators have very sharp cutting edges, and again these can lead to percutaneous injuries and cuts to the skin. And of course we all know about needle stick injuries. A large proportion, 90% of injuries, occurred in the offices and clinics of dentists. Only 9% were down to medical doctors, and then specialty outpatient facilities. And in that I'm probably thinking clinics that deliver these facial fillers and Botoxes. Amongst the dental hygienists, most of the injuries, 91%, were due to needle sticks, and the other 9% were due to cutting themselves with an instrument of some kind, most likely I would imagine a hand scaler. Among the dental surgery assistants, again not surprisingly, a big percentage, 86%, were involved needle stick type injuries, and then it was followed by dental instruments such as burrs or explorers or a scale or a scalpel, and then at 3% our suture needle, and then some other devices were 2%. So again, for the dental surgery assistants, the main one was needle stick injuries, but interestingly instruments as well at quite high, at things like the burr and scaler or scalpel. And of course we're going to be using quite sharp burrs for cutting bone, and certainly we're going to be using scalpels. Amongst the dentists, the majority of injuries were due to syringes at 82%, followed by dental instruments at 11%, or sutures at 7%. So again, we can expect that the likelihood is that we will impale ourselves with a suture needle at some point, or maybe an instrument. So on the clinics, please use the utmost care when using these instruments not to hurt yourselves in any way or cause percutaneous injury. The results of the 894 dental care workers with percutaneous injuries, there was evidence of HBV virus in 6 persons, HCV in 30 patients, and HIV in 3 persons. And in 2 persons there was HBV and HVC viruses. Now this is in the patients that they were treating, not in the healthcare workers themselves. So there were 3 seroconversions amongst dental care professionals who were exposed to HCV virus. So this is very serious because HCV is a very, very aggressive disease. It can cause liver failure very, very quickly. There's no treatment for it, so we must always be vigilant of HCV, and perhaps in areas of the Middle East this may be a more prevalent viral condition, and so one needs to be aware that the seroconversion for this virus is the highest. The others didn't really cause any problems at all. Now this paper discussed the findings, and they said that using local anaesthetic syringe and recapping were the most important causes of your needle stick injuries in dentists and dental hygienists. So they weren't using a recapping procedure, they weren't using a protector. Cleaning instruments, changing anaesthetic carpules and recapping were the most common activities leading to percutaneous injuries in dental surgery assistants. Interestingly, not cleaning the instruments wasn't a major cause. I would have thought that cleaning the instruments, or during the cleaning procedure, this would have led to a greater chance of possibly a needle stick injury or cutting yourself with a sharp implement. Practical points. Well, multiple injections may be given over the course of a patient's treatment. These activities obviously place the dentist at an increased risk of sustaining a needle stick injury. Therefore, I recommend that you give the entire anaesthetic cartridge to avoid the need to top up during the procedure, which often occurs when you don't give enough local anaesthetic. You see that dentists have to go back in and re-inject the patients who have now been subjected to pain. Their endorphins have been heightened, their adrenaline has been increased, and all these factors don't make it easy for the patient or the dentist. So remember it's most important to give the entire cartridge, both buccally and palatally, when doing implant surgery. If nothing else, this will reduce the frequency of injections you have to give, and by reducing that frequency will mean you are less likely to needle stick yourself. Out of hospital percutaneous injuries, there's a substantial risk to dental health care professionals. Improved work practices and safer devices are needed to address this risk. So these were the conclusions raised or identified in this paper, that really it's more likely to occur out of a hospital condition in a general clinic, and you have to be more vigilant in your work practices to avoid these incidents from happening. And if you're going to be doing implant surgery, obviously you increase the risk to getting other kinds of percutaneous injuries from sharp instruments, in addition to needle stick injuries. So we're going to look at this paper on improving the inspection and manual cleaning of dental instruments in dental hospital. And this study found that there was frequent occurrence to find residual cement contamination in newly opened kits that had just undergone a decontamination cycle. And any instrument found to be contaminated then cannot be used, as the area underneath the cement is not sterile, and in fact the cement itself, still clinging to the instrument, acts as a contaminant to the area as well. So this was a hospital practice where they found that it wasn't infrequent to find cement contamination on instruments which had been newly opened and prepared. 27% of the examination kits, in fact, had contaminated instruments in them. And if this happens, obviously you can't use the kit, and one has to open up a new operational kit, and this would increase cost and cause delays. Cross-contamination, since there is a chance that the cement may be displaced during use, so you can get an increased chance of this happening. And as I said, there's a cost involved in cleaning these and reopening them. And there's a time impact on the patient's experience, so treatment procedures can be unnecessarily prolonged, especially if there isn't a clean instrument pack ready. So when you're working in your practices, it's most important perhaps to ensure that you have your staff properly trained in cleaning instrumentation. And if possible, have two sets of instruments just in case one is contaminated. And even if it doesn't end up being contaminated, you may drop your elevator during the procedure, and so having a spare one, clean and sterile, is very useful and time saving. So, observance of sterilisation protocol guideline procedures of critical instruments for the prevention of iatrogenic transmission of Curettes-Jacobs disease in dental practice in France. Now, they were looking at the cleaning and sterilization procedures to prevent the transmission of spongy forming cephalitis to patients. The study, effective sterilisation of reusable instruments contaminated by Curettes-Jacobs disease in dental care, is a crucial issue for public health. Now, I would say not just because of this disease and prions, but also because of things like hepatitis C. This cross-sectional study investigated how the recommended procedures for sterilisation were implemented by French dental practices in a real-world setting. So again, the papers that I tend to favour look at the situations in general practice, not in hospitals, and these are general practices in France where one would expect a very high standard of adherence to sterilisation protocols. Dental practices with less than 3 dental units perform significantly better. They were above, they were 80% adherence. So we can say that basically the larger the clinic, the more units, the more surgeries in that clinic, they found that the adherence to sterilisation procedures dropped off. As a rule, practices complied poorly with the recommended procedures despite partially improved results in the bigger practices. So again, there wasn't good compliance to following sterilisation procedures. Recommendations from this study were specific training regarding sterilisation procedures and better understandings of the reasons leading to their non-compliance are needed. So why is it that these practices weren't complying to sterilisation standards and protocols? So the practical point is that the dentist must ensure instruments are sterilised according to the manufacturer's instructions. So when you get your implant kit, please make sure you understand how to properly clean and sterilise it. The practitioner and no one else is responsible for health and safety and for infectious risks in the dental clinic. So remember, it's you, the surgeon, that are ultimately responsible. These implant kits can sometimes have burrs with difficult to reach sharp areas, difficult to clean areas, and it's not uncommon sometimes to find that the surgery assistant has left a piece of bone from a previous patient on your burr. So before you use the burr in a patient's mouth, please carefully look at it and make sure there is no bone still attached from a previous procedure. It might surprise you in your own practices just how common this error is, in which case you can't use the burr, you have to send it back for cleaning, decontamination and sterilisation. One of the most common reasons for early implant failure is infection. Now that infection can arise from poorly cleaned, maintained and sterilised instrumentation. So as said previously, one cause for early implant failure is infection. And if this occurs, you should consider possible instrument contamination, and cross-infection should be considered as a possible cause and rectified if confirmed as the source. So if you start to get an increased number of early failures, then you should consider that it's down to instruments not being correctly cleaned and maintained. And as I've said, and I can't reiterate enough, implant instrumentation is very difficult to clean and maintain, and you have to be very vigilant that the instrumentation is kept as clean and is maintained as scrupulously as possible. This presentation has discussed the various tissue instruments used in order to raise flaps atraumatically and also to protect them during the implant placement procedure. It also has described their correct application and use, together with the various considerations which must be taken into account when it comes to maintaining the effectiveness of the instruments and preventing cross-infection due to poor cleaning and sterilisation procedures.